All right, for the next breakout session from ATSNJ 2021, really excited to have on our guest here, Dr. Charlie Gatt from University Orthopaedic Associates here in New Jersey. Dr. Gatt is the Chief of Orthopedic Surgery at the Rutgers RWJ Medical School, and he spoke to the topic of pain management for sports surgery. Can we be opioid free? And so, Dr. Gatt, thank you so much for talking about this very important topic for athletic trainers to stay up to speed on. And I want to get into some of your key takeaways from your presentation. The first thing is you talked about there's certain risk factors and certain things that you're looking for in the prevalence of opioid misuse in athletes. What should we be looking for? What are some of those risk factors and impacts in the prevalence of it?
I think the biggest risk factor is actually having used opioids prior to surgery. So, a lot of athletes have been to the emergency room with something as simple as an ankle sprain or a knee injury or shoulder injury, and they leave the emergency room, in the past. So luckily, it's not happening as much anymore, but sometimes as many as, 30 Percocets or Vicodin, and that's a lot of pain medicine for a relatively minor sports injury. Then they use them, maybe to get a good night's sleep after the injury, or maybe they are in a fair amount of pain. They get to know the feeling. So, but then, they've had that feeling. So now they come around and they actually need surgery where, sometimes you do need some opioids for pain control after surgery. And that seems to be one of the biggest risk factors for misuse of it after surgery. And that's, if you look at most of the research on it, you find that kids that have been given opioids for surgery have an up to 30% chance of misuse of the opioids after surgery, even into their college years. And it's not that it's chronic misuse; it's more, recreational misuse during their free and easy years, but it's not really necessarily a risk factor for chronic misuse, which is good news.
Yeah, definitely. And as you're looking at that post-surgical phase where there is a lot of pain to be managed, you had a lot of great ideas of what doctors are currently doing right now, non-opioid approaches. You did mention that we can't be completely opioid free. There are times if you're doing it responsibly, but for the most part, what are those non-opioid approaches you were talking about that can really help with post-surgical pain?
Well, I think number one, from a surgical standpoint, of the surgical techniques that we're using these days, especially for both the shoulder and the knee, use peripheral nerve blocks, and that's been a big bonus to us. Anesthesiologists can put in a very small indwelling catheter into the nerve that innervates the surgical field. And then in the past, the nerve blocks were 6 to 8 hour to maybe 10-hour blocks, and they would wear off. But now we're using what they call pain pumps, which basically drip a small amount of Marcaine onto the nerve for up to 3 days. The patient's just given a little elastomer ball, and it lasts for 3 days. They can actually turn it up and turn it down a little bit if they need to. So you find that will provide good pain control for up to 3 days. And again, if you look at most of the research on adolescent sports medicine surgery, number one, the kids only use about 1/3 of the prescription medication that they're given. And number two, most of them don't take narcotic pain medicine for more than 3 days after surgery. So where I do surgeries like knee arthroscopy under local anesthesia, or I was using preemptive analgesia for my ACL reconstructions and big shoulder reconstructions before the peripheral nerve blocks, I could always get them out of the surgery center or out of the hospital, and they'd feel great, for a day. But then it was the other 2 days that were the bridge, and now we have this pain pump, which I think has made a big difference.
Yeah.
The other thing is also just educating them before surgery, telling them that, you're having surgery and surgery hurts. I think for me, tell somebody, oh, this isn't going to hurt. That's not really realistic. Surgery does hurt. So if the kids have the approach that they know it's going to hurt, and I'll tell them, a lot of times you can control your pain with Advil or Aleve or Tylenol rather than going to the narcotic pain medications. If they hear that from me as a physician, I think they take it to heart and they really try. And to tell you the truth, with some of the modern techniques that we're using, a lot of the kids, the only narcotic they're taking is at nighttime and say, I really just took it to go to sleep, rather than not because they were having pain and they don't want to wake up, because they've all been forewarned, oh, you don't want to wake up in the middle of the night in really bad pain. But,
Yeah.
So they might use 1 or 2 pills after surgery, and that's reasonable. That's not so. And in light of that, what we've done is we've cut down the number of pills that we give them after surgery. We all used to probably routine 30 was like the magic number. Now I'm down to 15, actually as low as 12 pills a day, 12 pills as their prescription for after surgery. And very few patients will call for a refill. And we know now that they're not, left over with, 18 more pills that they don't know what to
Yeah.
do with.
And you also talked about mixing drug classes too, and how that can help also. Can you kind of speak to that briefly?
Sure. Multimodal pain medicine, again, and you see it with using anti-inflammatories like ibuprofen or naproxen combined with acetaminophen or Tylenol. You get they both have affect pain through different mechanisms, but by using both of them, both mechanisms are activated and you get an enhanced symptom relief by using the two different pain pathways or pain preventing pathways.
Yeah. And you mentioned the importance of education, and also during your presentation, you quoted a study where there were patients who saw a 2-minute video and they were provided education, and just that little amount of education made a huge difference in the risk of misuse. Can you kind of talk about the importance of education from the perspective of the athletic trainers who are working with these athletes post-surgical and also in advance of them having surgery? How can athletic trainers best educate our communities and the student athletes that we work with in this area?
Athletic trainers have such a great relationship with athletes. And for me as a physician, I count on that a lot. And, you guys evaluate the patients on the field. You decide if they need to go to the emergency room. And I think, number one of the things you can forewarn them is, hey, a lot of times I want you to go to the emergency room, make sure it's not a fracture or something bad. But if they give you any narcotic pain medicine, you might even want to think about refusing it. Or if you take it, take it very, be very careful with how you take it, and explain to them that, getting started on opioids because of an injury is a pathway to misuse of opioids. And I think when they hear that, their parents certainly know about it. I mean, it's all over the news right now, but I think the kids need to hear it directly from people they trust. And I know that, the athletes trust the athletic trainers. So that's step number one, is saying, you don't need to take narcotic pain medicine because you're in pain, because things like ibuprofen and acetaminophen and naproxen are more than adequate. A good ice pack, a good pressure wrap, all the primary first time care that you guys provide to them on the field. Then, if your athlete is, going to go for surgery, it's the same thing, the surgery, you're going to have some discomfort after surgery. The doctor is going to give you some pain medicine, but a lot of the procedures that are being done don't really require narcotics per se. And if we can get you back into the training room or get you into physical therapy early, even some of just the plain old soft tissue manipulations and soft tissue mobilizations that are done in the very early post-operative period provide pain relieving effects. So letting them know that it's like, for instance, when I do an ACL surgery, I start PT, no more than 2 days after surgery. And it's not that we're doing a ton of, moving the knee or anything. A lot of the early is just, soft tissue mobilization, getting rid of swelling and things like that. And that helps the pain tremendously. So again, we have non-narcotic, this is a manual way to help alleviate pain. And that's a big part of the procedure. So getting the buy-in from the athletes before surgery always pays dividends after surgery.
Dr. Gatt, thank you for talking about this important topic. In the state of New Jersey, of course, we know that athletic trainers have to have mandatory education annually in this, and absolutely all athletic trainers should be trained in the administration of Narcan in the event that there is an opioid emergency. Hopefully it never gets to that point around you, but it happens, sadly. So we have to be prepared for it. But thank you so much for talking about this topic. I appreciate everything you do for sports medicine and athletic trainers here in New Jersey, and continue to do those great things. So thank you.
Great. Thanks for having me.
All right. Have a great day.
You too. Bye-bye.